The standard Medicaid model is all or nothing. If you are poor enough, you get everything. If you make $1 too much, you get nothing. Oregon wanted to break this. They wanted to cover the working poor. Kishaber argued that it was more ethical to give basic care to everyone than high-tech care to a few. This is pure utilitarianism. The goal was to maximize the total health of the population with the limited dollars available. And critically, he wanted the rationing to be transparent. No hidden denials. The state would publish a list, and everyone would know what was covered and what wasn't. To create this list, they identified over 700 condition treatment pairs. A pair is a specific disease matched with a specific treatment. For example, pair 1 might be bacterial pneumonia treated with antibiotics. Pair 700 might be end-stage pancreatic cancer treated with chemo. They ranked these pairs. They used actuaries to determine cost-effectiveness, but they also held town halls across the state to ask citizens what they valued. Did the public value life extension over pain relief? Did they value mobility over mental health? They tried to bake community values into the math. Once the list was ranked from 1 to 700, the legislature drew a line in the sand. They looked at the budget. If they had enough money to fund items 1 through 500, then item 501 was cut. If the economy boomed and tax revenue went up, they could move the line to 550. If the economy tanked, they moved it to 450. It was a dynamic system. It meant that Medicaid beneficiaries had a legal right to treatments above the line, but no right to treatments below the line. It turned healthcare from an open-ended entitlement into a defined benefit based on value. This approach was haunted by the ghost of Kobe Howard. A few years prior, Oregon had tried to stop funding organ transplants to pay for prenatal care. Kobe Howard was a 7-year-old boy who needed a bone marrow transplant. The state refused to pay. Kobe's mother went to the media. TV crews filmed this dying boy. He became the face of rationing. Kobe died, and the public backlash was massive. This illustrates the rule of rescue again. The public theoretically agreed with the logic of prenatal care over transplants, but when faced with a specific weeping child, the logic crumbled. Kishaber knew the new plan had to be robust enough to withstand the Kobe Howard problem. When Oregon submitted the plan to the federal government for approval, the Bush administration said no. They cited the Americans with Disabilities Act, ADA. The problem was the quality of life surveys. Oregon had asked the general public to rate different health states. The public predictably rated life in a wheelchair as very bad. Therefore, treatments that left people in wheelchairs got a lower ranking. The feds argued this was discrimination. You cannot use the prejudice of the healthy to devalue the lives of the disabled. People asterisk and asterisk wheelchairs rate their quality of life quite high. Oregon had to redo the math to remove this bias. Oregon tweaked the formula, removing the suspect survey data and focusing more on medical efficacy. Does the treatment work? Rather than quality of life judgments. The Clinton administration approved it. The plan launched, and in many ways, it was a success. Oregon expanded coverage to over 100,000 people who previously had no insurance. They reduced the uninsured rate significantly. They proved that by cutting marginal treatments, like treatments for self-limiting viruses or cosmetic issues, you could afford to bring more people into the safety net. So, if it worked, why don't we all do it? Why isn't every state using the Oregon model? Because it is politically painful. Legislators hate going on record saying, "We will not pay for treatment, X." It gives their opponents an attack ad. Senator Smith voted to let grandmothers die. Politicians prefer asterisk, implicit rationing asterisk. They prefer to ration by queuing, waiting lines, or by price, deductibles, or by network restrictions. These methods hide the denial. Oregon made the denial visible. In American politics, transparency is often fatal. This fear of government rationing exploded again in 2009 during the Obamacare debate. Sarah Palin coined the phrase death panels, claiming bureaucrats would decide whether your grandma was worthy of life. While it was a lie regarding the ACA, it tapped into the real anxiety generated by experiments like Oregon's. Americans are deeply suspicious of any government body that holds a list of what is and isn't covered. We prefer the illusion that everything is covered, even if the reality is that insurance companies deny claims every day. The core ethical debate here is explicit versus implicit rationing. Explicit rationing, Oregon, is honest. It allows for democratic debate. If you don't like the list, you can vote out the legislature. Implicit rationing, the current U.S. system, is dishonest. It hides the decisions in the fine print of insurance contracts or the bank accounts of patients. Oregon argued that the hard truth is better than the comfortable lie. They argued that justice requires us to face the limits of our resources together, rather than letting the poor quietly fall out of the system. To conclude, Lesson 3, the Oregon experiment stands as a bold attempt to bring bioethics into the town hall. It forced citizens to grapple with the iron triangle. It showed that universal coverage requires sacrifice. To cover everyone, we cannot cover everything. In the next lesson, we will dive deeper into the math that Oregon tried to use. How exactly do we measure the value of a medical treatment? We will learn about the QALY, the Quality Adjusted Life Year, and the controversial role it plays in global health economics.